Og da vi faktisk klare med neste innslag på programmet. Vi hadde en liten teknisk utfordring her, men nå har det løst seg, så vi har fått med lyd fra Wien også, og der har vi Dr. Heinz Ludwig, som har forsket på det med livskvalitet og infeksjoner. Og vi har også med oss Fredrik Skjesvold, som vil svare på spørsmål og bistå på oversettelse der det mange. So, Dr. Heinz Ludwig, welcome to Norway. You should have been here in your own person, but we have you online, so that's we are very fond of.
Yes, thank you for the invitation. I'm at another meeting, but I'm sure Frederick is moderating your meeting in a very excellent form. And also thank Mr. Erdogan for organizing the meeting. So, Frederick, are you ready? I understand that you're going to summarize then what I'm saying here. And if it's okay for you, I'm going to start now. I'm talking about infections and quality of life in myeloma. I'm not sure whether you see my presentation in full screen. Do you see the presentation in full screen?
No, not yet. You have to put on the full screen symbol.
Yes, but I already shared it.
And at the downside of the press. There, no, not that.
No, it's different here with Teams. Teams is always more complex. It should be here. Are you able to see it now?
Yes. Yes.
Yeah?
Yeah.
Yeah?
We do it like this. Okay. That's okay.
Thanks so much. Thank you, Frederick. So, infection and quality of life, that's my topic. And probably during the discussion today, you have already talked about the risk for infections in patients. And the risk is already seen in patients with MGUS. As you see here, it's about 2 to 3-fold higher as compared to the normal population. But in myeloma, the risk goes up to 7 or 10-fold higher than compared to the normal population. And these are old data, but they are still hold true. And when you look at patients and when you ask patients before the diagnosis has been established, whether they had an infection in the year before the diagnosis was established, about 50% say yes, they had infection. Some had 1 to 3 infections, some had 4 to 6, and very few even more than 6. And after start of therapy, there's also a vulnerable phase because there's a higher risk for infections in all patients. And here you see in the first 6 months, 40% had an infection. There are many reasons why patients with myeloma are at increased risk for these infections. First of all, age. Myeloma is a disease of the elderly. Secondly, there are myeloma-related there's a myeloma-related immunodeficiency. So this varies from patient to patient, but it can be very significant. In addition, we have myeloma therapies, and particularly with the new myeloma therapies, the risk is very significant. And there may be multimorbidity, there may be treatment effects, and this is good news for women because their risk for infections is about 20% lower than in men. And when you ask how frequent are infections after start of therapy, when you look here on the left side of this slide, you see here, these are patients who are enrolled in studies with conventional therapy. These are patients enrolled who had first-line therapy, and these are patients who had a relapsed refractory myeloma. And you see here the incidence of grade 3 and 4 infections, very severe infections, varies about between 13 and 33%. And these are the data for pneumonia. But when it comes to novel therapies like bispecific antibodies, the risk is much higher. It's about 52% in patients treated with single agent bispecific therapy. And if you combine the bispecifics with other treatments such as CD38 antibodies or pomalidomide, lenalidomide, the risk increases further to about 70%. And the risk depends on the target of the drug. If the drug is targeting BCMA, the risk is higher as compared to patients who are treated with bispecifics, which targets other epitopes on the myeloma cell, such as GPRC5D. Now, why doesn't it move forward? When you look at the incidence of different infections after start of treatment with bispecific antibodies, particularly here is treatment is for treatment talquetamab is used. You see here there are more infections shortly after start of therapy, but when you look, for instance, at the respiratory infections, these are usually virus infections, the risk is still there after 1 or 2 years. But when you look at the data, you see that the risk levels off and becomes less pronounced with continuous therapy. There are 2 reasons. One is patients with poor risk discontinues the study. Patients with poor risk, with progressive disease, have a higher risk, and they leave the study here. So in the end, you have more good risk patients, and you have patients who are in remission, complete remission, and this is a situation where the risk is lower. And in addition, after long-standing treatment with these drugs, you increase the treatment intervals. So this reduces further the risk. And this graph here shows the risk for grades, for very severe infections, we call it grade 3 and 4. Now, when it comes to CAR T-cell therapy, there's a high risk shortly after the CAR T-cell infusion. Why? Because the patients receive lymphocyte depletion therapy here, and this has an enormous effect on the bone marrow. So when you look at the bone marrow cells or in the blood, in the peripheral blood, you see here thrombocytopenia, you see here low neutrophils, you see here significant anemia, and this is the composite data for all these types of cytopenias. It's very high after the end of the first month, and then it levels off slowly with improving time. The risk for infections is quite high in this period here, and which is represented here. These are the first 3 days, first 30 days. This is the risk for bacterial infections, the risk for viral infections, and when you put them all together, here you see the incremental risk for infections in patients receiving CAR T-cell therapy. So this is significant, and we have to recognize that about 20 to 25% of the cases with mortality are due to severe infections. Where are the infections? Most infections manifest in the upper respiratory tract or in the lower respiratory tract. These here are primarily virus infections. Virus infections suppress the immune system. They are the door openers for bacterial infection. So you start with a viral infection, and 2 or 3 days later, the patient develops pneumonia, which is mainly composed of due to bacteria. This is, let's say, a synergy between viral infections, which suppress the immune system, which open the door for bacterial infections. And these bacteria can come from the external sides, but it can also be what we call bacteria which are already in the body. And then you have other sites which are affected, and of course here's herpes zoster, which is reactivated quite frequently in patients. And here you have different types of bacteria which are reported in different studies. But I think this is very important here. There are also, you don't have to have, let's say, an infection which is manifested or which can be seen by computer tomography or by PET CT, because you can just have a simple bloodstream infection, but which can be very serious and carries a risk for even sepsis. So as mentioned, the majority of infections manifest in the upper respiratory tract and then move forward to the lower respiratory tract. The upper respiratory tract is very sensitive against viral infections, and then after 2 or 3 days, bacterial infections can cause pneumonia. But I have to say, it's not only bacterial infection, there can be viral and bacterial infections, or there is also the option that the pneumonia is only due to viral infection. So what is the situation of the patient? The patient, first of all, one important symptom for an infection is fatigue. Weakness and fatigue. This occurs suddenly with a few hours. And then patients suffer from fever and, importantly, from sweating. And night sweats are very common in these patients. There may be shaking skills, shortness of breath, there may be pain because of irritation of the pleura. And if patients are bedridden, there may be also an effect on mental awareness, cognitive function, particularly in very elderly patients. Influenza is something which you can almost suspect yourself. This is a viral infection which has a very sudden onset of fever. Patients have chills, and characteristically, those patients complain of muscle or body aches, high fever, suddenly occurring high fever, weakness, sore throat, muscle and body aches, and fatigue, as mentioned before, are characteristic signs of influenza, and that can be easily diagnosed. Your doctor can use a rapid detection test, and he can diagnose with simple tests influenza, and some tests include respiratory syncytial virus viruses, and some tests include adenoviruses. But if you have these symptoms, this is quite characteristic for influenza, and there are some drugs which may help you significantly. The most serious complication is sepsis. This arises from a pre-existing infection. It could also be a bloodstream infection. And when the immune system is weakened and cannot hold the progressive multiplication of bacteria, then there's overflow with bacteria, and which has a significant effect of organ function. So first of all, if sepsis is suspected, you need immediate hospitalization. There should be immediate start with antibiotic treatment, and the doctor will take blood cultures and will use additional medication to correct blood pressure, and maybe use some medication which is called vasopressors and provide fluid support and so on. So this is something which we have which we have to take very serious because it can be life-threatening. It can be, when it's severe, probably a patient will be transferred to the intensive care unit. So what are the consequences for an infection, severe infection? You need to, everybody can acquire a severe infection, all of us in the room and somewhere else. So if there is severe infection, we need hospitalization. Then a series of investigations starts: clinical, radiological examination, blood is drawn for blood cultures, antibiotics are administered, and we suffer from several complications. We are fatigued, we are weak, we shiver. There may be reactions to the antibiotic medication. Actually, we lose our autonomy and we are separated from our friends and family, and that has a negative impact, of course, no question, of our quality of life. So we have to try everything to prevent these severe infections occurring, but whatever we do, we cannot prevent them completely. Now, when we talk about quality of life, it's very difficult because there are different definitions for quality of life. Usually, what is important for us? Our physical health, no question, our mental situation. We need to be independent. For quality of life, social relationships are very important. The quality of life is also, let's say, shaped by our personal beliefs. And of course, we want to be with the environment we are used to be. So how do we measure quality of life? In medicine, we focus on these different items, and we use so-called instruments, which are standardized. This is the most frequently used instrument. It's called the EOITC Quality of Life C30. C30 because it includes 30 questions. And the patient is asked to respond to these questions. So whatever, do you need to stay in bed? Is this really true? Do you need to stay in bed all the day? Well, not at all. So a patient usually responds to these 30 questions, and then you can use this information, which is can be very helpful for your care team. You can do it as it was done previously. You can just use a pen, or nowadays your center may offer an electronic version where you do it at home before you meet your physician. So when you answer to all these questions, I should add there are additional instruments. I just mentioned that is not the only one, but this one is the most frequently used one. It has also a myeloma model. So what do we do with this information? Well, you can compare the impact of different treatments on the quality of life of patients who receive these different treatments. For instance, here, the treatment Velcade and dexamethasone was compared with carfilzomib dexamethasone in patients with pre-treated myeloma. And when you look at the general health score, general health status, you see KD, carfilzomib dexamethasone, is a clear winner. It was also superior in improving physical functioning, role functioning, and it reduced fatigue. It reduced pain more than Velcade dexamethasone, and there were less side effects of treatments. So this gives you very valuable information for what you should select, which treatment you should select for you personally, and which treatment will your care team recommend to you. And when you do it sequentially, you see here KD is significantly superior during the entire course of therapy. So this is important information for our patients and for the care team. Another example is shown here. We believe, or most of my colleagues believe that, sorry, there is a typing error. So this should read KRD, and this should read KDD. So we compared here Revlimid with thalidomide. So here it's correct. So usually people believe, first of all, I should say KRD and KDD result showed similar anti-myeloma activity. So the question is, which one is better tolerated by patients? And when you look here at the graphs, the red graph shows you patients who are treated with KRD, carfilzomib, Revlimid, dexamethasone, and those are treated with carfilzomib, thalidomide, old thalidomide, dexamethasone. But their global health status with thalidomide was much better than the global health status in those patients which have been treated with Revlimid. So our colleagues wouldn't anticipate that because we believe that Revlimid is better tolerated than thalidomide. But that is not true. For instance, Revlimid has a negative impact on cognitive function at the beginning of treatment, and it causes more fatigue and insomnia here. But thalidomide causes more neuropathy. Now, so this is clear. In theory, you could select what's better for you. But we also looked at the impact of carfilzomib on maintenance therapy. So in dark, the dark lines denote patients who received carfilzomib maintenance therapy, and those patients in green were just observed, so had no maintenance treatment at all. And here you have, so these are these are the patients who had observation, and these are the patients who had carfilzomib maintenance therapy. So usually when you ask the patients who are on carfilzomib maintenance therapy, they say, I'm doing quite well, I'm fine. But when you compare objective data, those without maintenance, carfilzomib maintenance, dark lines here do much better. And the same is true for physical functioning, role functioning, social functioning. There's more neuropathy with carfilzomib, slightly more fatigue, and particularly more insomnia. So also we anticipate it's going very well. If you look very carefully, you see that patients have symptoms, but the patients adapt to these symptoms, expecting the benefit of carfilzomib is relevant for them in prolonging maintenance therapy. So it's easy to accept it if you really expect a significant improvement of your maintenance duration. Another example is shown here. When patients have 5, 6 or more lines of therapy, it is really difficult to assess whether they are progressing or not because their tumor cells have lost or the ability to produce the protein which we use for measuring progression or remission. So the capability of the myeloma cells is decreased to produce the protein. So and that is not considered in our present day or response assessment, of course. So, but when patients show detrimental quality of life, here we have physical function, and in green we have pain. This starts earlier. Earlier, patients record this earlier before we physicians are really able to assure that the patient has progressive disease. This is something just to keep in mind for our colleagues. Now, there's something which is important in my opinion. We did a study regarding neuropathy. The patients were treated with bortezomib. And here you see the polyneuropathy as assessed by the patients. And in blue, that is grade 1 and 2. And in dark red, this is grades 3 and 4, more severe. This is less severe. And you see here, during the course of treatment, the incidence of more severe neuropathy increased. And here, the incidence of less severe neuropathy decreased slightly. But when you compare this with the evaluation which was given by the investigator, you are surprised because the investigators did not realize the impact of neuropathy on patients' well-being, because they graded severe neuropathy only in very few patients, and they misgraded the extent of neuropathy in most patients and said if the patient has something, it was usually grade 1 or 2. So this is important for the caregiver to learn to listen to the patients and to ask twice whether this neuropathy is disturbing, is painful, is hindering them in walking or whatever. So what are the benefits of quality of life assessment for patients and for caregivers? Because we are a synergy somehow. So if you do these assessments before you have the consultation, the caregiver, the physician, knows already about your well-being, which is very important because they can identify critical symptoms. They can easily implement proactive treatment. They improve the quality of the communication between patients and physicians, and patients sometimes overestimate their well-being. Patients have the capacity to adapt. And by using these instruments, you can avoid or reduce unnecessary suffering. And that should lead to better outcome. But there's also a benefit for new developments, because myeloma therapy has improved significantly. But we cannot stay where we are. We have to move forward. We have to improve results. And we can only show whether a new treatment is effective by comparing this treatment with standard therapy. So we need to compare different treatments. And then when you have seen the comparison between different treatments, and that you can, using these instruments, you can identify subtle differences between different treatments. So it's very helpful for research. It also is important because patients consider these instruments as very helpful. They help their caregivers to better understand the situation. Of course, these instruments reduce the workload and help to improve the designs of clinical trials, because the focus is now, a very important focus is now on patients' well-being, which is sometimes more important than PFS and sometimes even than overall survival. With that saying, I come to my final comments. protect yourself against infection as much as you can. You should have these vaccinations. At least this is our recommendation. So it's a full package: influenza, pneumococci, herpes, so the respiratory syncytial virus and COVID-19. And that is something which you have to discuss with your caregiver, because not everybody needs antibiotics or antivirals, only if you are in a specific risk group. But what is important for you, for your family, for the caregivers, adhere to hygiene recommendations. Quality of life. Being confronted with a diagnosis gives you often an impetus to reflect your prior life. And by reflecting your life, you can set new goals, which sometimes will improve even your well-being, which you think that may be counterintuitive, but it is reality. You should focus on issues which give meaning to yourself, which give pleasure to your life. You should be able to enjoy the little positive moments of every day. And I hope you agree with us, we should be positive that myeloma therapy is improving and the cure is becoming very closely in reach. With that saying, I would like to thank you for your attention, and I thank Frederick. He will make an absolute excellent summary of what I have just presented. Thank you very much.
So, thank you, Heinz. Very nice to have you at least virtually present. So I think I think your talk was very clear, but I think I will want to give the opportunity to the audience to ask you questions, and if needed, transfer that to the mic here, and they can also ask the questions in Norwegian. So, er det noen som har noen spørsmål til Heinz? Han hører nok ikke dere, så jeg kan si spørsmålet, eventuelt oversette. Dere kan gjerne spørre på norsk, det er jo like enkelt, siden jeg uansett må si det inn i mikken. Noen som har noe dere lurer på?
Forstod jeg han riktig at lav temperatur også kunne være tegn på en infeksjon?
So there's a first question here, Heinz. Did the patient understand you correctly that also low temperature could be a sign of an infection?
Yes, that is usually seen in very elderly patients when the temperature drops down. Usually if you have these infections, you have increased temperature, fever and so on. But you shouldn't take it for granted that the patient has no infection when his temperature is lower. So one should be careful. But physicians know this and are careful, particularly when it comes to very elderly people.
Jeg tror på en måte hovedpoenget at man skal ikke tenke at man ikke har en infeksjon fordi man har normal temperatur. Det finnes jo også feilkilder i hvordan man, i de målingene. Det er jo ikke alle som bruker termometer der det egentlig hører hjemme lenger. Og de andre har visse feilkilder ved seg. Så man skal ikke, hovedsakelig er det hvordan pasienten har det, hvor syk det virker, som er viktig på en måte. Andre spørsmål? Ja.
Jeg har vært på en studie hos dere en gang, og utfylt noen quality of life-studier mange ganger. Og spørsmålene har du smerte, har du bevegelseshindringer og så videre? Det har jeg, men det skyldes ikke myelomatose, og heller ikke behandlingen. Og jeg har vært så veldig i tvil om, skal jeg sortere hva som myelomatose-symptomer, eller skal jeg si hvordan jeg har det totalt med, totalt.
Yeah. So Heinz, there's a question here from a patient who has been in clinical trials and filled out a number of these quality of life forms. And she's wondering, should she fill out just answering the questions as they are? Or should she evaluate whether this problem that she might have is related to myeloma or not? Let's say that she has bad mobility and she knows that's not because of myeloma. So should she answer the questions just bluntly as they are asked, or should she try to evaluate herself if the connection to myeloma when answering these forms?
I think she should answer the question at the but when it comes to the consultation with her physician, then she should, of course, explain that she has these symptoms, but they may be due to other reasons for morbidity, like activated arthrosis or whatever. So this should be a point of discussion with her caregiver.
Thank you. I will translate it. But in the meantime, Heinz, could you turn off this screen sharing so we can see you in full screen?
What can I do? Thanks so much.
Yeah,
Is
perfect.
it now?
Så svaret på spørsmålet var at man skal fylle ut bare sånn som det er. Har du problemer med det, skriv det, ikke tenk på hva det skyldes. Og grunnen til det er at man sammenlignes jo med andre som har myelomatose, og det er jo i en loddtrekningsstudie for eksempel, så skal alle svare på det på samme måte. Og hvis alle skal begynne å tenke over mer komplisert enn det, så tror jeg ikke vi kan stole like mye på svarene. Og så bare la han til at men disse tingene, hva som skyldes myelomatose og ikke av dine og andres problemer, det må man diskutere med legen på visitten på en måte.
Jeg bare lurte på om jeg forstod det rett. Dexamethason, kan det begrense en infeksjon?
There's a question about whether dexamethasone can limit infection.
Whether dexamethasone can limit what?
Infection.
It can induce, actually it suppresses, if you take high doses, it suppresses the immune system and it increases your risk for infections. So we have to keep that.
But the question is still, it does increase chance of infection, but if you have an infection, is there sometimes relevant to use dexamethasone?
That was old practice when patients had a viral infection, viral pneumonia, then they received dexamethasone or corticosteroids. I think nowadays we should use antivirals as far as they are available. So it's a controversial field, but we would abstain from using corticosteroids. We would, when there is viral pneumonia, we would try to figure out whether it's due to adenovirus, CMV reactivation, respiratory syncytial virus, and then start treatment with antivirals.
Så i hovedsak så skal man ikke bruke dexamethasone til behandling av infeksjon. Det er nok noen unntak med pasienter som er intensivbehandlet, der det kommer litt mer komplekse ting inn, der dexamethasone kan hemme en del ting som går ut av kontroll, men ikke for å behandle infeksjoner. Andre spørsmål?
Okay. Jeg har gått med en forkjølelse, bihulebetennelse og hoste siden begynnelsen av august. Jeg har vært behandlet med antibiotika, aposilin, og det tok det grønne slimet, men jeg er fremdeles forkjølet. Hvor lenge skal en myelomatosepasient, kan dette bli en kronisk tilstand hvor jeg resten av livet skal være forkjølet?
Hva slags behandling er du får?
For myelomatosen, eller for myelomatosen. Jeg har fått en studiemedisin elnaratamab, og den fikk jeg så mye bivirkninger av i første sekvens at jeg ble tatt av medisinen. Den virker fremdeles i kroppen min, så M-komponenten er jo sust nedover, som jo er veldig bra, men immunforsvaret mitt er så lavt at jeg ikke føler at det er immunforsvaret som gjør at jeg blir gående med en forkjølelse.
Dette var i tilbakefall, ikke sant?
Ja.
So Heinz, there's a patient who started treatment with a bispecific antibody, BCMA, targeting, and pretty quickly stopped the treatment because of several side effects, but has since been having continuous infections, sinusitis and common cold symptoms, and just asking how long should she expect to be sick?
That's a difficult question. First of all, one should check her IgG level. If the IgG level is low, then one would recommend IgG supplementation. So there are different opinions regarding treatment of respiratory infections, upper respiratory tract infections. But if it's very severe, if the symptoms are very severe, I would start with immune globulins. If that is not helpful, we would discuss it with the patient, and we would probably also suggest to use Tamiflu.
Come back to that. And how long? The question was, how long should she expect to be like this?
I think it depends. If there's something which you can easily correct, like low IgT levels, she should have relief within the next 1 or 2 infusions. If the infection does not depend, is not due to low IgG, then probably it's more complex because she needs active T cells, and our bispecific antibodies reduce not only B cells but also T cells, and so she has to wait to recover until the T cells recover and are able to control the infection. So it's difficult to say it in an individual patient. But I think all in our experience, everybody who had these problems, and these are quite frequently upper respiratory viral infection, recovered. But it sometimes may take several weeks.
Ja, så det han svarte, det jo først at man må ha immunglobuliner. Det antar jeg du på. Ja. Han nevnte også Tamiflu som en influensavirusmedisin, som vi for så vidt ikke har brukt så mye i denne situasjonen. Men det er et interessant poeng at vi snakker mye om hvor bra det er med disse bispesifikke, men dette er jo et av problemene med bispesifikke antistoffer. At for det første tar det liv av, vi har type 2 typer immunceller som skal hjelpe oss mot virus og antibiotika, for å si det litt enkelt. Det er B-celler og T-celler. B-cellene er jo den familien til myelomatose-cellene, og de blir jo borte, mer eller mindre. Så der kan man fylle på med immunglobulin, sånn som de fleste med bispesifikke får. Og som også Gunhild nevnte og fikk i starten etter KRT. Det andre er at behandling i seg selv bruker T-cellene som behandling. Det er jo T-cellene som aktiveres mot kreftcellene. Og de blir ofte utslitt, og det skal mer til jo mer behandling man har fått, eller det skal mindre til jo mer behandling man har fått fra før, og også så er det noe med alder, der de T-cellene er mer utslitt når man blir eldre. Og dette, vi har sett mange eksempler på pasienter som har gått med rinovirus, som er liksom viruset bak vanlig forkjølelse, i månedsvis. Da bruker vi å stoppe behandling hvis dette er klinisk plagsomt, men selv uten behandling så kan det ta månedsvis før det blir bra igjen. Det blir bra til slutt. Vi har ikke sett noen som ikke har sluttet, tror jeg, men sikkert noen som er underveis. Men hvis man fortsetter med behandling, så blir ofte denne infeksjonen bare varende. Kronisk forkjølelse, rett og slett. Så eneste måten å få bukt med det på, det er å stoppe behandling og la det gå tid. Og samtidig så er jo ofte disse medikamentene så effektfulle at du kan tåle å stoppe ganske lenge med behandling uten å få tilbakefall. Så vi har ikke, de aller fleste pasienter vi har hatt på disse medikamentene har ikke fått tilbakefall, selv om vi har hatt lengre pause i månedsvis. Men det er et kjent problem, og tidsangivelsen er vanskelig. Det kan absolutt gå måneder. Altså. Yes, andre spørsmål? So Heinz, just one question to end this. Could you say something in general about how to balance? I talked a little bit about this earlier today. How to balance the need for, efficacy, best possible effect, and quality of life in treatments that are continuous. How should the patients think about that?
I think this is very much dependent on the patient's situation. If it's a first-line therapy, one should also consider the adverse events and probably consider using another protocol, but there are not so much alternatives. If the patient has already had 5 or 7 or even more treatment lines, he's more willing to accept side effects for possible gain in survival. So the more difficult the situation, the more is the patient inclined to accept side effects for gaining more longer survival.
Ja, det han svarte, som dere jo hørte, at det er litt forskjellig etter hvilken situasjon man er i. Jo tidligere i sykdommen er, jo snillere sykdommen er, jo lettere er det å ha en høy terskel for å akseptere bivirkninger. Og kunne leve, egentlig ville helst ha et liv uten noe særlig bivirkninger, med det som da trengs av dosereduksjon eller eventuelt avslutning. Mens jo lenger du kommer ut i sykdommen, og jo færre alternativer du har igjen, så er man kanskje i større grad nødt til å akseptere en viss på en måte, mengde bivirkninger for å holde sykdommen i sjakk. Men også der kan det være situasjoner der det absolutt er fornuftig, ofte vil jeg si, å likevel gå ned i dose og finne noe man kan leve med. Jeg tror hovedpoenget er at hver enkelt må ta stilling til selv. Er dette en situasjon jeg kan leve godt i, sånn som det er nå, eller må vi gjøre noe tiltak for å endre det på en måte?
Okay.
Do you agree, Heinz?
Yeah. Thanks so much.
Noen som har noen flere spørsmål dere brenner inne med? Do you have anything, final statements, Heinz?
Yes, I think, of course, the patients often ask after a consultation what they can do in addition. And so what can they do in addition? I think there are many things. They can be on a healthy diet, and there are some data that vegetarian diet or vegan diet has a little effect, at least in animal models, on the outcome. So it has some effect. So a healthy diet is important. Physical activity is important, if possible. It should be endurance training and power training. And then, of course, it is you should focus on things which you like, which gives you meaning, which gives you satisfaction. You should continue with your social life, because that is a very important network. And having something which you like, which you love, is important. And in the end, we have to be thankful that we are here, and because every day has some positive sides. Even if it's a difficult day, think on the positive sides and focus on those, and try to diminish the negative experiences.
Ja.